So we're here again to take a look at some of the concepts that we've utilized over time. So specifically here, we're going to apply the concepts of working on soft tissue perpendicular to fiber direction with respect to the anterior compartment of the thigh. So the thigh being essentially the lower limb between the hip and the knee, or between the pelvis and the knee, depending on the terminology you'd like to use. When we talk about working on soft tissue in osteopathic manual therapy, I've discussed before that it's primarily the methodology that is used is working perpendicular soft tissue fiber direction. So if you happen to know the fiber direction, it's advantageous. In the case of the anterior compartment of the thigh, it's essentially vertical, right? So what we're going to do is also invoke the concept that when working on soft tissue, it is useful to attempt to shorten the soft tissue that you're working on, especially if it has an opportunity to not be at rest. One of the interesting things with the soft tissue of the anterior compartment of the thigh in a supine position is that it is essentially relaxed, so you are quite often able to work on it. So what would happen, again, we are talking about moving perpendicular to fiber direction. We're also considering that contact is control and control is safety and relational motion. So one thing stays still, one thing moves in relation to it. So I would stabilize the thigh, and I've shown a method like this quite a bit, and I would push and pull the soft tissue broadly of the anterior compartment of the thigh across the femur, right? Now I can hold the soft tissue still and mobilize. You can't see my down table hand here, but basically you can see me wiggling the thigh. So I'm going to create motion in the tibia and fibula, or with the tibia and the fibula as my contact point or my handle. I can keep the soft tissue of the thigh still and wiggle or move the femur under it, so that's an option. With respect to shortening these soft tissues, so as I said, in a supine position, the soft tissues here are fairly relaxed in most people in this position. What we can do though, because many of these soft tissues of the anterior compartment of the thigh cross two joints that cross the hip and the knee, if we create hip flexion, we have shortened some portion of this. Now, although the knee has essentially gone into flexion, which would mean that you'd have some stretch of these tissues, what we've done is, in a relative sense, closer to the hip, we've shortened some of the tissues. So you will still have some opportunity to work reasonably well at the hip, right? So we can, if we are having a challenge getting the result we want here, now keeping in mind that one of the reasons that the soft tissues of the anterior compartment of the thigh are somewhat relaxed in this position is because the knee is extended here, so you've essentially shortened the soft tissues at the knee by creating knee extension. So that's the reason why you're going to get a reasonable, or it's part of the rationale why you're going to get reasonable motion of these soft tissues. But there are times when you want to work in close to the hip, right? You want to work closer to the superior portions of rectus femoris, or other hip flexors, or even some of the quadricep muscles, depending on what your goal is, or if you're just not necessarily segregating, but you're working on all of them collectively. You will have the opportunity here to get a different result when you shorten, or when you create hip flexion, because you'll shorten these tissues here. You can still do the same push-pull. Now I can hold, and I can essentially move the femur at the hip. So we were using relational motion again there, where my hand is staying still on the soft tissue. So relatively speaking, I'm keeping the soft tissue still and moving the bone underneath it. What the most ideal position to shorten all of these tissues would essentially be a straight leg raise. So I would have hip flexion and knee flexion. So the patient's leg would be fully straightened and elevated. That becomes somewhat cumbersome if I'm actually trying to work on these muscles. So essentially, I'd have to place the patient's leg on my shoulder, and then that becomes awkward and cumbersome. So in a supine position, the anterior soft tissues, or the soft tissues of the anterior thigh, are exposed, free to move in the planes required, right? And the patient is fairly stable because the table makes stable. So we're talking about the concepts of patient positioning there, right? So all of these things are again displayed, or can be used to describe why I would often work on these soft tissues in this position. I may, if I want to work more proximally, I may create hip flexion, I may not, depending on the situation. I can work in there. But again, just to take the time to talk about these concepts, re-demonstrate them with respect to these particular soft tissues, we we take this time to share all of that with you. Again, to be explicit, to purposefully demonstrate all of this. So realistically, it just looks very simple. I can either move the soft tissue over the relatively still bone, or hold the soft tissue still, move the bone underneath it. Right? So all these concepts keep coming back together to inform how we will describe treatment approaches and assessment approaches.